you guys are. I'm here in New York. It's pretty cold here, so I assume you're not here, right? So let's start with history. History is fascinating. I always like to read about it and find out what was happening over the years. You probably heard of the infamous hospital, which called Bedlam. It's a hospital that was actually founded in England by English King Henry III in 13th century. That time it was founded. I have a circa of 18th century. That was many hundred years after it was actually built. It was moved from one place to another, but it was known for horrible conditions. And also there was a movie called Bedlam. Actually, it was a horror movie with famous British actor Boris Karloff. I don't know if you're familiar. He was one of the original. He was the original Frankenstein. So he was in that movie, 1946. So that's how it started. I mean, of course, patients with mental illness and patients with the intellectual disabilities were not differentiated. Everybody was in the same facility. In United States, there's one famous person that I want to talk about, Dorothea Dix. She was one of the pioneers of an advocate for mental disability, for patients with mental disability. She spoke about any people with developmental disability, not necessarily people with intellectual disability. But at that point, everybody was in the same category again. This is a very emotional quote. The present state of insane persons confined within this commonwealth, talking about the United States, in cages, closets, cellars, stalls, pens, chained, naked, beaten with rods, and lashed into obedience. Irritation of body produced by other fields and exposure inside it, talking about one woman, to the horrid process of tearing off her skin by inches. Her face, neck, and person were thus disfigured to hideousness. That was said in 1843. Many things changed then, but it didn't change. It stayed like in very serious disarray for many, many years after Dorothea was living. There's some pictures that I found of the institutions where actually the system started to differentiate people with mental illness and people with intellectual disabilities. At that time, people with intellectual disabilities, perhaps some developmental disabilities, were called feeble-minded children. And again, of course, it's not just children, it's anybody who had developmental intellectual delay. This is the picture of institution from northern upstate New York, Syracuse. This is one in Newark. This is the, again, institution for feeble-minded women only. It's in Newark. If you're familiar with New York, it's just outside of New York City, already state of New Jersey. This one in Pennsylvania, that's already 20th century, circa of 1903. Again, Penhurst Institution for Feeble-Minded and Epileptics, Spring City, Pennsylvania. So again, the term feeble-minded was used from the late 19th century in Great Britain, Europe, and the United States for disorders later referred to as illnesses or deficiencies of the mind. At the time, mental deficiency encompassed all degrees of educational and social deficiency. Within the concept of mental deficiency, researchers actually establish hierarchy ranging from idiocy at the most severe end of the scale to imbecility at the median point and to feeble-mindedness at the highest end of the functioning. I believe that somewhere even in the 40s, they used the term moron for those who are at the highest end of functioning. Later, those terms, of course, became obscenities and we're not using them anymore. But back then, it actually was medical terminology. believe it or not. So the development of the ranking system actually was attributed to Sir Charles Trevelyan in 1876, and it was actually associated with the rise of eugenics, something very controversial science used later by Nazis, again, unfortunately. At the same time, they came up with those terms that still used now as idiot savant or autism. So I don't know if idiot savant is still being used, but I heard it. I mean, it's again, it includes the word idiot, which is quite not a very pleasant word to use these days. So basically, the American eugenic movement argued that all people who were mentally ill, mentally retarded, or physically disabled, again, you see, I used the term mentally retarded. This talk was actually originally developed many years ago, before DSM-5 came up, and mental retardation was the official term used. So I had to change the whole slides and presentation, but somehow still combination of mental retardation comes through. I left this one on purpose just to remind it to myself and to you that this is something that we used before, and things actually changing over the years. There's nothing wrong with mental retardation, but unfortunately the term was used to as obscenity again, just apparently outlive itself. So such individuals with intellectual disabilities were seen as a threat to society and the probable cause of most of the criminal activity and social problems of the country. Actually, it's true not only about developmental disabilities and intellectual disabilities, it's true about any any patients, any people with mental illness. So, and especially so with developmental disability. To these days, I think many people do not know the difference, unless you're a professional or you're in the field. The people don't know the difference between people with schizophrenia and people with intellectual disability. And back then, it was even more of a problem. So in many states, and we're talking about 20th century, support for the eugenics actually resulted in legislation which required mandatory sterilization, incarceration, and in many cases, the castrations of persons with disabilities. A lot of horrible things were happening, and it was not that long ago. In each state, hundreds of thousands of people with mental illness or intellectual disabilities were actually placed in institutions. And the largest of those places were housing as many as 20,000 people. I'm going to talk about one of those institutions here in New York State, actually in New York City. Finally, in 1940s, it was decided that precepts of eugenics movement were invalid. However, by that time, hundreds of thousands of people with intellectual disabilities or mental illness had been admitted to state institutions. In the 1960s, state institutions across the nation housed more than 150,000 people with intellectual disabilities only. I'm not talking about just mental illness. This is just people with intellectual disabilities. And unfortunately, it was very common to keep more than 100 people in one bedroom at the time. People were naked and lying on the floor to cool off because they didn't have air conditioners, of course. They had inadequate ventilation. It was filthy with excrements and urine on the floors and walls, and the odor was horrific. And that's something that was going on for decades until something started to move when President Kennedy came to power. He came up with the Community Mental Health, Mental Retardation, still called Mental Retardation Act, in 1963. So his quote, mental retardation ranks with mental health as a major health, social, and economic problem in this country. It strikes out our most precious asset, our children. It's a little bit, it's not accurate necessarily, because again, this is not just striking children. People were suffering, people of all ages were involved in suffering. One of the main reasons actually the Kennedys were involved, that I don't know if you know, they believed that one of their sisters, Rosemary, was actually mentally, intellectually disabled. Let's say that. They did not know her whereabouts until 1961, when I think Kennedy Sr., their father, became, I think he had a stroke, and at that time he lost his capacity, and the whereabouts of their sister was finally revealed to them. Apparently she was not born with intellectual disability, and according to this, to the classification as we know it now, she wouldn't be classified as intellectually disabled or developmentally disabled. It's interesting that she had lobotomy at the age of 23. And after that, I believe she developed some cognitive decline. Probably you would call it dementia, since it happened after the age 22. And she lived a long life, dying only in 2005 at the age of 86. Very interesting story. You can read a book about her. Again, she's not happened to be intellectually disabled, but her siblings believe that she was. And that could be something that made them act. I'm talking about President Kennedy and his brother Robert, who also was involved in helping these people later on. This is the place that I was mentioning before. It's called Willowbrook State School, one of the most notorious places where horrific abuse took place. If you're familiar with New York, it was located on Staten Island, and it was open actually as an army hospital. It started to admit children, mostly children, because parents could not have their kids, and they couldn't keep them in the families. I think the society was against it, and I think they were even mandated to actually place them in those facilities. Very, very horrible situation. And it stood open for 40 years. So it's built in the late 1930s, was a state-supported institution for mentally retarded, intellectually disabled children, was located in central Staten Island in New York City. Well, again, I already spoke about it. They didn't receive first residence until after World War II. By 1965, they had more than 6,000 residents, even though the place was planned for no more than 4,000. And the Senator Robert Kennedy, who again, he participated in helping patients with intellectual developmental disabilities, he did call Willowbrook a snake pit. However, somehow it was kept open because it required huge funds to deinstitutionalize Willowbrook and place clients elsewhere. So again, conditions continued to worsen despite all of attention that the school had. This was another horrible thing happened in the same place, and it took place somewhere between 1963 and 1966. You would be amazed to find out, if you didn't know, that apparently the inhabitants of the Willowbrook institution, state institution, were intentionally injected with the virus of hepatitis that actually caused the disease. The practice very similar to what Nazis did 25 years before them, and actually condemned for the practice. Believe it or not, in this country in 1960s it was done to living beings, to people. And these studies were designed to gain an understanding of the natural history of infectious hepatitis, and subsequently to test the effects of gamma globulin in preventing or combating the disease. And in some cases, parents couldn't even admit their children to Willowbrook. Doesn't mean that they could keep them home. They probably had to send them elsewhere outside of New York, far from where they are. But if they wanted to be here in New York, in Willowbrook, they had to agree to participation in one of those studies. Eventually, the case caused public outcry, forcing the study to be discontinued, but not earlier than 1966, sorry. In November 71, Staten Island local paper, the Staten Island Advance, published a series of articles detailing the horrible condition of the school. Only then, following these articles in January of 1972, the famous reporter Geraldo Rivera, who I believe currently is on Fox Channel, Fox News, at least that's the last place I saw him. He began a series of programs that actually shook the conscience of New York State and the nations, and inspired finally parents and others to take legal actions. The end result was the signing of a consent judgment in federal court in 1975. But believe it or not, the closure of Willowbrook did not take place until 1987. And that closure was linked to that judgment signed in 1975. The former grounds were redeveloped, extensively to serve as the campus of the College of Staten Island. But many of the buildings were knocked down due to their excessive neglect and need for major repair, but a lot of original buildings are still there. And some of the buildings are still being used as residential facilities for patients with intellectual disabilities. I had a patient who was a survivor of Willowbrook, and up until these days, he would just go and roam the grounds of Willowbrook at least once a month. It's hard to explain why he was doing that. He did suffer from severe PTSD. He was very high functioning and kind of patient with autism. And this has really changed their lives. And the best to learn about the place is to watch this excellent documentary. It's called Unforgotten, 25 years after Willowbrook. It was filmed in 1996, actually. It's less than an hour, but it's very emotional and very educational, and I highly recommend you to watch it if you're interested in the subject. If you have anybody in your family who's affected, you have to watch this movie. It's very educational, and you will learn a lot of things from it. So now a little bit about the present time. I have data from 2013. It's a little bit outdated, but nevertheless, there's almost 30 million people in the United States with different types of cognitive disability. Out of that 30 million, almost 12 million people have mental illness, not necessarily just per se cognitive disorder, but just severe persistent mental illness causes cognitive decline. Then you have more than 6 million people with different types of brain injury. Almost 5 million people have Alzheimer's. People with stroke account only for less than 1 million people. But out of this whole chunk of people with cognitive disability, intellectual disability includes almost 5 million people. What's interesting that prevalence of children diagnosed with developmental disability actually increased from 2014, 2016. Again, it seems to be outdated, but it's not that important because at that time when they studied the problem, they found that amount of children who were diagnosed with intellectual disability did not change. And same could be said about autism. So only patients with children with developmental disabilities, that number was a little bit higher, maybe due to improved diagnostics and improved awareness. But the number of people with intellectual disabilities seem to be stable over the years. It does not change. The system, the delivery of help for this population suffered major setback in early 2000s. I don't know what was the reason, but the funds provided by federal government were seriously cut. It coincided with the time of Obamacare. I don't know if there's any connection, but at that time, many government-funded clinics were closed, shut down in New York and in the entire country. A 2004 report from the National Association of State Mental Health Program Directors, the research association, outlined the problems that this population was facing. First of all, although 80% of individuals with developmental disabilities in state institutions have a co-occurring diagnosis of mental illness, only 7% are served in the units specializing in treatment for both conditions. So if you have a patient who have intellectual disability and mental illness, it will be very difficult to find a psychiatric unit which would be able to accept that person, would be willing to accept that person. Most of the time, they've been discharged from the emergency rooms and sent back to their residences, which have to deal with the situation and keep the patient together with the other residents. And the most significant difference between individuals with developmental disabilities in state hospitals and the rest of the hospital inpatient population is that those with developmental disabilities on average have much longer lengths of stay. And that's why I think majority of inpatient units do not want to admit them, don't want to see patients with especially severe and profound intellectual disability on the unit. Especially if the person comes from the community, not from the group home. A lot of time, families bring the patient to the emergency room, the person is being admitted to the inpatient unit, and then the family doesn't want to take them back. If this is like a state institution or city hospital, I think there's a requirement for the government to provide the housing for the person within 6 months. If this is a private institution, there's really no time frame. The person can be confined there for like years. And we had such situation in our hospital because we are actually a private hospital. That creates a big problem. All right. Okay. Well, this is some recommendation of the organization that I mentioned before, what should be done to improve the situation. Again, the recommendation was, recommendations were made in 2004. To tell you the truth, from my experience, since I work in both worlds, it did not improve significantly, if at all. We still don't have specialized units for patients with developmental or intellectual disabilities. They still being held in emergency rooms for many days. The reason that, for example, our hospital keeps the patient in the emergency room because the placement from emergency room takes the priority. So with the state regulator, the agency that's responsible for taking care of patients with intellectual disabilities involved, their priority is to place the person from the emergency room. then from city and state hospital, and only then from the private inpatient unit. Well, again, the idea was that mental health and developmental disability systems, which are two different systems, should work collaboratively with each other and other service systems, especially primary care. It does not happen, unfortunately. For example, as Alexandra mentioned, I was the director of Developmental Center, which was opened after scandal with Willowbrook in late 70s, and unfortunately shut down in 2008 because of lack of funds. From what I was saying, the beginning of 2000 came as a crisis in the field. And at that time, our chairman wanted to take all the patients from developmental disability systems, which called, there's an agency called Office of People with Developmental Disabilities. He wanted to simply take those patients and treat them within the general Office of Mental Health system. If you're familiar with New York, we have Office of Mental Health here, and we have this Office of People with Developmental Disabilities. Technically, both of those populations have mental problems. But Office of Mental Health said they will not finance or allow people from the other system to be treated in regular mental health clinic. Here you go. So that was 2008. Our clinic was, the patients with developmental disabilities were totally excluded from mental health system and put in the regular system with internal medicine. Internal medicine tolerated our patients for about 6 years, and then they said, we don't want to have those people here because they scare our regular patients. And this is 2015 we're talking about. Where's political correctness? It's totally, it's hard to explain why it's happening, but it is happening. And the hospital simply referred them out. So the situation is dire at this stage is still in. There's no improvement, and there's no finance coming to help patients with intellectual disabilities. Well, there's one major change that happened. Now I want to talk a little bit about DSM-5. Well, we didn't get a lot of money, we didn't get a lot of help, but we developed some different classification, I guess, as a trait. So DSM-5 defines now intellectual disabilities, no longer mental retardation, as neurodevelopmental disorders that begin in childhood and characterized by intellectual difficulties, as well as difficulties in conceptual, social, practical areas of living. DSM-5 diagnosis of intellectual disabilities requires the satisfaction of 3 criteria. First of all, it's deficit in intellectual functioning. So that's something you should take home. It's not just IQ that defines the person being intellectually disabled or not. There's some other things. The most importantly, it's deficit in adaptive functioning. Somebody can have IQ, high IQ, but totally unable to function adaptively. It could place the person in developmental disability. To become intellectually disabled, you have to have both. And again, the onset of intellectual disability should occur before the age of 18. This is an important thing to remember because, first of all, if the child develops normally and then becomes cognitively impaired, if it happens before 18, you can classify this person as intellectually disabled. You don't have to be born with intellectual disability. On the other half, if something happens to you at the age of 18, like let's say motorcycle accident or something, that would be traumatic brain injury and you cannot be diagnosed as intellectual disability. Yet, if it happens before the age of 22, you can be classified as developmentally disabled. Again, as I mentioned, intellectual disability replaced mental retardation in DSM-5. And well, those revisions brought the DSM-4 into alignment with the terminology used by the World Health Organization. and other professional disciplines and organizations such as American Association of Intellectual and Developmental Disabilities and the US Department of Education. We're talking about DSM-5, this is psychiatric classification. Not every one of you is going to become psychiatrist, but the psychiatric classification was a little bit behind of ICD classification. Again, developmental disability, that's different from intellectual disability. Intellectual disability, on the other hand, is a subset of developmental disability. Developmental disability is defined, is defined as severe chronic disability in individuals 5 years of age or older. So if you have a child who shows signs of developmental delay until the age of 5 and recovers by the age of 5 and catches up with the peers, then you cannot actually call this person developmentally disabled and, of course, intellectually disabled. So if that persists after 5 years, then the person will be classified as developmentally disabled. If developmental disability happens after the age of 22, like in the case of Rosemary Kennedy, then it's just dementia or traumatic brain injury or whatever happens that causes cognitive decline. If it, however, happens before age of 22, including accidental brain damage, that would be classified as developmental disability. So there's a window between 18 and 22. If something happens to you and you develop cognitive decline, you would be classified as developmentally disabled. If it happens before 18, you would be intellectually disabled. All right. So then also you have to remember there's such thing as autism spectrum disorder. That's a little bit different. It also belongs to developmental disabilities. If you have autism, you definitely belong to developmental. You'll be classified as developmentally disabled. Those usually are conditions that you're born with. Not every person with autism has intellectual disability. The other condition called cerebral palsy that people born with, also classified as developmental disability. And 25% of patients with cerebral palsy have normal intelligence. If you find time to watch that movie I recommended you, Unforgotten, one of the characters there, a real person, somebody who had cerebral palsy and was placed in Willowbrook institution and actually grew up there with normal intelligence. And this is a very tragic story, but at the same time, it's a story of success. After he was released from Willowbrook, finally, he was able to get education. He became one of the executives in one of the associations that takes care of patients with these issues. And he is a living witness of what happened, what horror happened, and what kind of abuse happened in that institution. Again, its name is Unforgotten, 25 years after Willowbrook. Highly recommended. Please watch it. And it's probably more interesting than listening to my talk today. Mental illness is very common in people with intellectual disability. It's a very known fact. But they also have a lot of physical health problems, which can affect their mental state. As a matter of fact, the number of medical comorbidities are much higher in patients with intellectual disability for different reasons. Difficulties in communication can contribute to mental health problems being overlooked. And it also can present with changes in behavior. The first intervention when you're dealing with these situations is always psychological management. Verbal de-escalation is always preferable to prescribing psychotropic medications. Behavioral approaches are the most appropriate way to manage challenging behavior. And the best way to approach this person to have somebody who's familiar with the person, maybe a family member, maybe caregiver. They know the person much better than, you know, mental health provider who never met the person before, or people on inpatient units and emergency rooms. If you deal with somebody with intellectual disability, the first thing you should do, try to contact the collaterals, find the family members, find the people who know them, and that will help you a lot. Okay, what is different when you're dealing with people with dually, you're dealing with patients who are dually diagnosed? Dually diagnosed means mental illness and intellectual or developmental disability. First of all, as I said, increased risk of common side effects and higher rate of unusual and rare complications, including medical issues. There's a high rate of anticonvulsants and antipsychotic medication use, and those medications have lots of side effects and potential drug-drug interaction. This is definite overuse of such medications with the goal to sedate the person, subdue the person. A lot of times it's used without any merit. A lot of times the patients with intellectual disabilities simply cannot communicate problems that they have, such as pain or maybe hunger. It can be considered a mental illness or act of aggression, when in reality this is something very simple. So you have to be very careful before you start treatment with medications. The second half of my talk, which I'm not going to cover today, but when I present it to my colleagues, I usually concentrate on treatment of these patients. And that includes some key points of psychopharmacology, what should be done, what shouldn't be done, when it should be used, and what are the indications for medications. Of course, you have to try to treat specific psychiatric disorder, but it's extremely hard to diagnose somebody who is nonverbal with, let's say, schizophrenia. A lot of times, as I said, the patient can be suffering from toothaches or nightmares. You don't know, you simply don't know. And when you see somebody with profound intellectual disability and diagnosis of schizophrenia, you have to be very skeptical of that. And when somebody is diagnosed with schizophrenia, as you know, it just goes from one evaluation to another, from one paperwork to another, from one discharge summary to another. But who was the first one who decided to say this person has schizophrenia? We don't know. I had patients who absolutely couldn't talk, and yet they were carrying diagnosis of schizophrenia. And I'm sure they were grossly misdiagnosed. And that also defines the treatment. A lot of times, the treatment focuses at severe disruptive behavior. And those behaviors usually include aggression or self-injury, and behaviors that fail to respond to behavioral intervention. This whole field is very challenging. It has more challenges now than it had before. It might be somewhat different. The public's awareness has improved a lot, but nevertheless, we still face major obstacles in delivering services to this population. And if you become psychiatrist, you will have to get special training. You should try to get special training in dealing with these patients and learning the ways of helping them. If you're not going to become psychiatrists, if you're just general physicians, you also have to be aware that this population is different. You have to be aware of the challenges that they're facing. And hopefully my talk will help you in understanding of what the core issues are at this time. And again, watch that documentary. I have a lot of material to cover in general, so if you invite me next time, we can continue, but at this time I'm out of time. I'm open for questions. Thank you guys for your attention.
Thank you, Dr. Trackman, for giving that overview and history lesson. I know I needed it, and I'm sure other people on the call as well did. Like you said, we're open for questions for about the next 10 minutes.
Hi, Dr. Trachten. My name is Daniel. I'm a third-year medical student. Thank you
Hi,
again
Daniel.
for giving this talk. I really appreciated your deep dive into the history of this issue.
Thank you.
So just because, like, I know these patients, they have a significant psychiatric comorbidity. Um, what's your perception of other providers, other specialists, and your advice to them for when giving care for this population?
Well, first of all, try not to stereotype those patients. You
Okay.
need to understand that the actually those people with developmental disabilities are not, they don't have high risk for aggression.
Mhm.
If they engage into some stereotypic behaviors, making loud noise, pacing, for example, it doesn't mean that they're dangerous to other patients. You need to educate your other patients and help them to accept these people, not to exclude them from your waiting areas. That's what happened to me in my experience with my Maris hospital. And the issue was mismanaged. And we're talking about now, we're not talking about 1960s when we were injected with hepatitis, or beginning of the century when it was still eugenics and Nazis doing experiments on people. It is now. Everybody is concentrating on financial benefits. And the idea was that these patients will scare the regular patients out of the clinics and the proceeds will go down. You should be aware of this issue, of this nonsense, and hopefully when you become in charge, not only as a clinician, but as an administrator, you would understand this population better. And again, if you watch not only my talk, but those documentaries, especially the documentary that I recommended, you will really remember that it will be in the back of your mind that that documentary is extremely emotional. And at this point, I have the experience. I see that people who have family members with intellectual disability are much more accepting than people who didn't come across of those patients, of those people. And this is like a sad thing. And unfortunately, people have to suffer to understand other people's suffering. And that's not how physicians supposed to be. You need to learn how to have empathy and understand what are the obstacles and what are the living conditions that these people have to face, and help them to get the proper proper care. So that's my take.
All right, thank you. Thank you again.
Thank you. It's a good question. Well, if there's no question, can I ask you guys what actually brought you to this conference? What is your personal interest in developmental disabilities? Because I see there's only like 20 people here, right? Alexandra?
Yeah. So my interest in developing the conference actually stemmed from listening to a mother and son combo that we'll hear from in the family panel, Dr. Lisa Weisinger and Jamie. I took a class for intellectual and developmental disabilities over the summer, and they were speakers during the class. And Dr. Weisinger, who's an internist, was talking about the difficulties that Jamie was finding with mental health care, and it really got me thinking about access to care. I'm an M4 and going into psychiatry, and that's one of my passions, to increase access. And when we talk about that a lot, when we talk about lower socioeconomic statuses, but there's other ways to increase access, and one of them is through teaching more about IDD and how that affects children and also adults, and how, that is an underserved population within psychiatry. So I kind of just wanted to bring light to the subject and education to it as well.
It's been a challenge. It's been a big issue, actually. As I said, they started to close the outpatient psychiatric facilities that were set for just this population. And it's been going on for like almost 20 years now. Like in New York City, if you have a child, forget about adults, like let's talk about children with intellectual disability, you cannot find a psychiatrist. You cannot just find somebody who will medicate them. I had a patient who had depression and was getting Prozac, and my clinic, my Mariners hospital, right, like outpatient division, they said we cannot treat her because she's almost nonverbal. Office of Mental Health does not allow us to accept these people. It's like, where's she supposed to go? They said, we don't know. And there's really no place to go. She ended up being prescribed Prozac by a neurologist. This is insane. I mean, and this is what's going on right now. And I don't know what the solution is. And if you're an adult with developmental disability or intellectual disability, especially, and if it's severe or profound disability, there's no way you can find a prescriber like a psychiatrist. Not even in the city or state hospitals equipped to accept these people because they belong to Office of Mental Health. I don't know what the solution is. This whole entire New York City has 1 or 2 clinics, which has waiting list of like 6 months and more to treat these people. So they end up being in emergency rooms, sitting there for days and being treated by psychiatrists, of course. So, and at this point, that's the situation. You guys have any other questions? You have a couple of minutes.
Just for me, so I'll talk about my interest in psychiatry in this topic. So yeah, I'm a 3rd-year student, so I've completed my psychiatry rotation. Some advice that I was given by my residents and stuff is to kind of like look out like the professional groups like APA, and that's how I found PsychSIGN to help kind of like develop my interests. And I was interested in this topic just because of this this challenging population. Even on my non-psychiatry rotations, like when this population comes up, it's definitely a challenge. So I just want to learn more about what I can do to be better in treating this population, and hopefully maybe provide something more as a medical student when I see some more people of this population when I do my 4th-year rotations.
Very good, very good. It's actually some overlap between neurology and psychiatry in this field. This is a neurodevelopmental psychiatry. They even have a board of neurodevelopmental psychiatry. So it's a special field. It's a little bit different from Freudian psychiatry or psychoanalysis, but it's more towards medical part, neurology. And it's very fascinating. And I hope situation will change to the better. And I think this is 10:50, Alexandra. Thank you for inviting me.
Yes,
thank you for the opportunity to speak to you guys, and good luck to all of you in your future profession, endeavors, whatever you guys take. Thank you for joining me.
All right. Dr. Trackman, that was great. Thank you for your talk. We are going to now have a family and patient panel. I'm very excited about this. It's one of my favorite times of the day. It's going to be more informal. I'm going to introduce the families, and then we'll hear a little bit about their stories, their children's stories, and we'll open it up to questions from participants. So again, we ask that everyone turn on their camera if you're able, so that we can all see your faces and it's a little bit more intimate setting. So our panel will feature Dr. Lisa Wessinger and son Jamie, and also Miss Jennifer Sherman and her child Gavin.
Hi, everybody.
Good morning.